lecture. So as you see, the topic today is functional and aesthetic crown lengthening, optimizing the outcome with the interdisciplinary concepts. However, with the limited time, and I've talked with Dr. Uvo, and I probably will mainly focus on aesthetic today rather than talking both concepts, okay? So as Dr. Uvo introduced me before, I'm originally from China. So I did my DDS in China, it's called a BDS, and a PROS training in China. And then I came to United States in 2014. So more specifically, I came to NYU. So I spent actually 6 years there. And this is a great facility with a great faculty, great dental educational resources. And we even have a new building to facilitate the student to be able to study and practice on the type down and the nice clinic. And also, I was very impressed by what Dr. Uvo was doing about the Healing Hands Health Society. Because actually in NYU, we have the similar program. It's the Global Outreach Program. It's been there for many years, and we've been to the different city of the world and all of the world, and then trying to help with the remote country and places to help them to give them more dental resources. Unfortunately, due to the COVID, so this we cannot continue at this moment, but hopefully after COVID is completely over, then we can join the family of the Healing Hands Society and do it together. So in my 6 years in NYU, I've completed a lot of achievement in the training of prosthodontics as well as surgical, including, for example, sinus, implant, GBR, and soft tissue augmentation, as you can see here. And one of the things that I also valued a lot is they trained me how to do dental photography. So unfortunately, right now, I don't have my Instagram account for dental yet, but hopefully in the near future, I will be able to open my Instagram account and share with you the beauty of dental photography. So let's start today's topic, crown lengthening. As we all know, it is a surgical procedure used to expose a greater tooth structure while maintaining the biological width. The indication for crown lengthening includes insufficient abutment, subgingival fracture, deep caries, as well as aesthetics. So today, as I said, I'm going to focus mainly on aesthetic crown lengthening. So let's start with the basic concept, biological width. So based on the classical literature of Gargiulo in 1961, there are 3 components for this dental gingival unit. It includes a sulcus, junctional epithelium, and connective tissue attachment. So each component is roughly 1 millimeter. And these 2 components, which are the junctional epithelium and connective tissue, are so-called biological width, which is roughly a number of 2.04 millimeters. And according to the recent word workshop, we officially changed this term in periodontics. We officially changed this word to supracrestal tissue attachment. So if in the future you're reading some literature and you see this terminology of supracrestal tissue attachment, it is we call it biological width. So they're the same concept. So why is biological width so important? Based on the study by Tarnow in 1986, it's a human study. So what he did is he intentionally violating the biological width. So here you can see this is the regular tooth with a normal prep, but here the T represent temporary. So he put the temporary intentionally into the junctional epithelial area. And then he extracted the tooth and did the histology and see what's going to happen for this tooth. So in this study, it shows at 1 and 2 weeks post-treatment, the new gingival margin showed a mild to moderate inflammation. Within 1 week post-crown placement, apical migration of the junctional epithelium presented. And furthermore, following this migration, the resorption of a crestal portion of the facial plate occurred. So basically, here are some clinical features of violating biological width. And as you can see, usually patient will have a chief complaint about chronic pain. They will say, I always feel discomfort after the crown has been inserted. I don't know why, and everything looks normal. And sometimes you will see this linear gingival inflammation only around the restoration, such as in this picture. And also you will see some localized gingival hyperplasia, such as here, and of course, a bleeding upon probing. And furthermore, if you don't treat this early symptoms or early sign in time, it will eventually cause gingival recession, pocket formation, and bone loss. So if we know our restoration margin will need to extend into the junctional epithelial zone, then we have to intentionally remove some bone to make room for the biologic width. So that's why the purpose of doing the crown lengthening. So here comes the question, how much millimeter is enough for the bone reduction? So the first literature I want to mention is the very classic literature by Ingber in 1977. This is the article must to know for the crown lengthening. So in this article, he suggests that we need to remove or maintain the 3 millimeter distance to be able to facilitate the biological width. However, if you read more articles, you might be a little bit confused with all those different numbers. As you can see, it seems like each author has their own numbers, and some are similar as 3 millimeters, but some can ranging very differently than the 3 millimeters. But here I want to explain why these numbers are so different. If you really look into detail about each articles, you realize each number actually represents a different reference point. Whenever the author mentioned about 3 millimeters, it basically are talking about from restorative margin and to the crestal bone. So if the reference is restorative margin, it's usually always 3 millimeter. And for the bigger number, the authors are actually using a different reference point, such as fraction line or tooth structure. So basically, don't confuse yourself when you're reading articles. The 3 millimeters is the gold standard considering about the bone reduction in the crown lengthening procedure. And the reference point is from the crestal bone to the restorative margin. And I actually just mentioned about biological width as around a 2 millimeter. So someone may be wondered, don't you just say the biological width is 2 millimeter? So why 3 millimeter? Where is the other 1 millimeter come from? So that's a very good question. The reason for that is traditionally when we do a PFM, and back to the old days, we don't just do a supragingival or equal gingival margin. We usually will do a bevel to hide the restorative margin under the gingival line. So in this way, there's roughly around 0.5 millimeter to 1 millimeter bevel depth. So this 1 millimeter comes from here. So therefore, here comes the 3 millimeter by Ingber and explain to you why there is 3 millimeter based on maintaining the biological width. And the second question usually people ask is how many months is enough for the healing of this crown lengthening procedure. So based on some basic literature for the wound healing, we can see here for the epithelium reattachment, it usually takes 1 to 2 weeks. And for the connect tissue formation, it usually takes 4 to 8 weeks. For the periosteum, it's 3 to 6 months, much longer. And for the connect tissue maturation, is 6 to 9 months. And for bone stabilization, it definitely needs more than 6 months to heal. So here we have actually 2 different phases of the healing. One is early healing. It usually takes less than 2 months. And another one is late healing. It's more mature healing. It takes around 3 to 6 months. So the question is, why do we need to wait longer? Can we just do the final restoration once the epithelium attachment is healed, which is probably like 4 weeks? And the reason is we have this phenomenon called tissue rebound that usually happens after crown lengthening procedure. So here are two clinical situations just to show you what is the tissue rebound. The picture listed on the left are the immediate post-op with the suture, as you can see. And here are the 2 months post-op. So if you draw a line and you can appreciate how much tissue has been shifted from the apical to the coronal. And for the top cases, it's probably around 1 to 1.5 millimeter tissue rebound. But for the bottom cases, as you can see here for the lateral, it's almost have a 2 to 3 millimeter rebounds. And this is a coincidence with the correspond also with the literature that has been published about this article, about this the topic of tissue rebound. So as you can see, there are different ranging from the tissue rebound. Some authors, such as Lengthening and Dees, and they report around 0.5 millimeter tissue rebound. However, on the other side, the Ponteraro and the Bragger, they reported roughly even the tissue rebound can reach 3 millimeter. So let's take a close view for the article of Ponteraro 2001. So in this article, the author suggested the finding of during the 1 year of healing period, the marginal tissue kept coronally shifting. And the first month showed the greatest coronal growth. And the coronal growth decreased and maintained after 6 months. So as you can see, many authors has been suggested you better wait long enough for the tissue to stabilize and not to do the restoration too early. So all those authors are suggesting the 6 months is the minimum healing period after crown lengthening, especially for crown lengthening. However, on the other hand, there's also some author and give a relatively shorter healing time, such as Lenny in 2003. If he finds there's no significant changes between 3 to 6 months, and he also suggested that the 3 months healing seems sufficient following the surgical crown lengthening, even in the aesthetic areas. So basically, according to Lenny, you can do the final restoration within 3 months. However, what I want to point out here is this most important sentence here is if you want to do the final restoration within 3 months, you need a sufficient amount of osseous resection. So here comes the factors affect the outcome. So how can we prevent the tissue rebound? How can we shorten the healing period? There are basically 2 types of factors affect the outcome and the healing period. One is technical, another one is anatomical. So for the technical factors, including flap positioning, osseous resection, as well as root preparation. And for the anatomic factors, it mainly talking about periodontal phenotype, which also called periodontal biotype. So among all those factors, for me, myself, and as well as this article listed here by Dr. Ernesto Lee, I totally agree with the article, and I think the most important factor here is the osseous resection. The achievement of the stable gingival margin requires a surgical approach where the clinical crown length desired is achieved through sufficient bone removal instead of a soft tissue manipulation. So if you ask me which one is more important, flap manipulation or osseous resection, you have my answer. And then if we look back to the article that I actually mentioned by Ponteraro, and it shows the tissue rebound is 2.9 millimeters, which is almost 3 millimeter tissue rebound. And if you look detail into this article, you will see in this article, the mean osseous reduction was just 1 millimeter, and a bone resection more than 2 millimeter only happens at 8% of the size. Compared to the article by Lengthening 2003, which the tissue rebound is only 0.26 millimeter. And as you can see in this article, at 90% of the treated sites, more than 3 millimeter of bone was removed. So it proves again, the osseous resection is directly related to the tissue rebound. So sufficient osseous resection is very important. And another anatomic factors of a periodontal phenotype for personalized, a quick case. It's not a full cases, but I want to show you how important is the osseous resection here. So here's a patient. Actually, this is not my case. I only took the picture, and I was not one who did the surgery. So thanks, Dr. Zahidi, for sharing this case with me. So as you can see here, the patient came with a chief complaint of a short clinic crown and a little bit gummy smile. So the patient was asking the improvement for the crown shape. And as you can see, once we open the flap and then see the anatomical crown is actually much longer than a clinical crown. And this is so-called altered passive eruption, which I will definitely go into depth in the later slides. So what we did is we did the osseous resection and close the flap, and this is the immediate post-op and 2 months post-op. So as here you can see that the clinical crown has been like lengthened, and the patient was pretty happy about the result. So this is the initial and on the left, and then compared to the 2 months post-op, the central here is not too much. It's probably only 1 to 1.5 millimeters. But if you compare to canine, the canine is much more lengthened. And you know, of course, for every aesthetic cases, when patient is happy and the final result was beautiful, you always ask patient to put some lipstick and just come back with a happy mood, and you take a bunch of shots, and you know, just for documentation, and you can see how happy and patient is. However, 3 years later, and the patient came back to the clinic again, and she said, I don't know why I feel like my tooth went back to before. So I was like, what do you mean by that? So I took a picture and I put 3 pictures together of initial 2 months healing and 3 years post-op. And if you draw a line here, as you can see, even although the canine is pretty well maintained, but if you look at the central, it's almost went back to the same as initial level, and you don't really see any lengthening anymore. And also same for the lateral here, you see a certain amount of tissue rebound. And then I asked of the surgeon for the surgical pictures, like, can I take a look of your surgical picture? So when I look at the surgical picture, and I realized at that time, I think the osseous reduction at the time by the surgeon was not sufficient. So it is an insufficient osseous reduction that caused this tissue rebound at a 3-year post-op. So the take-home message here first is the healing time in the non-aesthetic zone, I will say 2 to 3 months is probably will be sufficient. In the aesthetic zone, I would recommend for 3 to 6 months. But if you want to do 3 months, you better to do a sufficient osseous reduction. And the factors affecting the outcome will include flap management, root preparation, periodontal phenotype, and as I mentioned again, sufficient osseous reduction. And for the osseous resection in the thin biotype, I will recommend for 3 millimeter. And in the thick biotype, I will recommend more than 3 millimeter. So now here we finished those introduction part, and we're going to talk into detail about the aesthetic crown lengthening. So many patients may present into your office and with the similar chief complaint saying, doctor, I don't like my smile. I have a gummy smile. I don't like my crowns. I have a short crowns. So they may have the similar chief complaint. However, the etiology and diagnosis of each case behind are different. And actually the more correct, proper terminology here is excessive gingival display. And as I mentioned, each cases may have a completely different etiology. That makes the evaluation for diagnosis really very important. So I think there's the evaluation including 2 parts. One is for the aesthetic, another is for the periodontal. So I'm going to start with the aesthetic evaluation first. The first parameters I want to mention is the incisal edge. According to Frank Spears, the maxillary central incisal edge is the key to aesthetics and the functional treatment planning. And this incisal edge also can be affected by many factors such as race, sex, upper lips length, and as well as ages. Especially ages is what we need to be familiar with. For example, if a young patient like 25 years old present into your clinic, and you should know this patient should relatively show around 3 millimeter incisal edge, compared to if a patient is like 40 years old presenting into your clinic, and which will show relatively only 1 millimeter incisal edge. And there's also several ways to determine the incisal edge, such as you can use the phonetics and certain pronunciation. And I think in different language, you have your own words and the pronunciation to check the phonetics of the position, to determine the position of the incisal edge. And another one is check the incisal edge exposure at the lip in repose position, which should be 1 to 2 millimeters, but differs by the age. And also you can use the occlusion. Some people will use the anterior guidance to make sure to determine whether the incisal edge needs to be lengthened or not. And the most common and easier way is actually use this curvature of the lower lip just to check if the maxillary, the anterior incisal edge are following this convex gut wing curvature of the lower lip. So here's a quick example to show you how important is incisal edge. This patient was referred to the perio department for a crown lengthening procedure. As you can see, it is kind of obvious when you first got the case, because the central incisor, number 9, which is the left central incisor, has a much higher margin. And compared to this one, all the other margins are relatively lower. And so the treatment planning that the restorative dentist wanted me to do is crown lengthening for the anterior 3, to matching the level of the left central incisor. However, I did check the incisor position of the patient and realized the patient's incisor position is shortened and should be lengthened. Therefore, I discussed with the restorative dentist, and we agreed to change the treatment plan to a completely different manner. So eventually this case become a root coverage case. So the restorative dentist will have to redo all 4 anterior crown, and probably a slightly gingivectomy on this one, but mainly is a connective tissue graft for the root coverage procedure of the left central incisor. So as you can see, it's one cases, but the treatment plan can differ from one to the other just by the way that you evaluate the incisal edge. And the second important part that I really value a lot is the tooth proportion, and which is the width-length ratio. There are many classic literature and talking about this width-length ratio, and like Stera, Manganese, and Dorate, they're usually talking about number of 80%. And however, there's also some Japanese authors mentioned that in the Asian, there's a relatively smaller number of the portion, which are the 70%. But basically, all the articles are ranging from 70 to 80% of the crown root ratio, the width-length ratio. So basically, we're using mainly the width because by the aging, and you have some sort of a worn out facet, and especially for the incisor edge, it could be chipped and it could be worn out. So we're basically using the width as our reference point. So according to Chu's article, he listed a certain mean number of the anterior 6 tooths, such as for the central is 8.5 and lateral 6.5 and the canine 7.5. So if you adapt those ratios of the width and the length, and can easily come up with the number that how much the length the tooth should be. For the central is supposed to be around 11 millimeter, lateral is 9, and canine is 10. And also for Dr. Chu, he also invented this Chu gauge, which is called T-bar. So as you can see, he automatically already put these numbers into the T-bar, and the percentage, the ratio of this T-bar is around 78%. So if you want to determine if the patient needs a crown lengthening or not, you just need to put this T-bar into patient's mouth, and you see there's a little platform here. So this is where the incisor edge sit on. So you sit incisor edge on the platform, and you can directly tell from the red dot or the blue dot or the black dot, and see how much more you need to lengthen the crown. So that's basically how you use this T-bar. So basically, that's the two most important parameters for aesthetic evaluation that I think. And of course, there are definitely way more parameters of aesthetic point that you need to really look into detail. But I just listed the two that I think is more important. And after that, the aesthetic evaluation, then it comes with the periodontal evaluation. For the excessive gingival display, there are so many differential diagnoses. According to Dr. Robinson, there are several differential diagnoses for the excessive gingival display, such as pathological gingival hyperplasia, vertical maxillary access, dental alveolar extrusion, short or hyperactive maxillary lip, as well as altered passive eruption. And as I mentioned before, today I am really going to go into depth of this altered passive eruption. So based on this article by Dr. Nard, it's actually very common to be seen in our daily practice. It's almost 30%. So what is an altered passive eruption? I want to give a little bit definition of this term. So basically we have a tooth phase when the tooth erupt. There's active phase, which means the tooth emerges into the oral cavity. And there's a passive phase, which means the apical migration of the soft tissue. Yes, sorry. When this passive phase is interrupted or disturbed, and therefore the soft tissue will not go apically, this is what we call altered passive eruption. So it is first determined by the Goldman Cohen in 1968. They determined this terminology as altered or retarded passive eruption, which means the gingival margin in the adult is located incisal to the cervical convexity of the crown. And later on by another author, they also mentioned about delayed passive eruption. So basically, if you read articles, you see the terminology of altered or retarded or delayed passive eruption. They are all the same. So here, I'm just going to call it altered passive eruption. And for the classification of altered passive eruption, the most popular articles to cite is Koslet in 1977. So in this classification, there are two types. Based on the width of keratinized tissue. So type 1, you have a wide band of keratinized tissue. For type 2, you have a narrow band of keratinized tissue. And within this type 1 and 2, there's a subclassification as A and B. For type A, you have sufficient distance from CEJ to the bone crest. However, for the type B, the bone osseous crest is very close to the CEJ. And the same thing for the type 2. And for each type, there's actually a corresponding surgical procedure recommended. For example, for the type 1A, the recommended surgical procedure is just gingivectomy only. And for the type 1B, is gingivectomy plus osseous reduction. When you don't have enough keratinized tissue, which we all know is very important for maintaining the natural tooth health, you need to do an apical position of flap. And if you have a very close osseous to the CEJ, and you have to do the apical position of flap together with osseous reduction. So how to diagnose this altered passive eruption? I really hope you can get this out from this presentation, because I really think this like clinical appearance and this diagnosis was most oftenly not addressed in the clinical daily practice. So you can tell, you can diagnose altered passive eruption by the clinical appearance. But most importantly, you need to do a quantitative evaluation, such as X-ray, bone sounding, and CBCT. But I will say, if you really start to look at your cases for the patient who has a cheek complaint of short crown and gummy smile, 90% of the case, you can almost directly diagnose this by the clinical appearance and X-ray. So the typical clinical appearance for the altered passive eruption is short or squared clinical crown, and all the 6 anteriors are normally affected. And the excessive gingival display is usually more than 2 millimeter, and it usually happens in a thick, flat phenotype patient. So for example, for this case, if this patient presents in your clinic, and quickly you can tell those tooths are very square, and the width-length ratio is almost 1:1 ratio, like 100%. And then if you take a close view of the patient's X-ray and draw a rough line at the CEJ and draw a square box, and you can automatically come up with the ratio that is around 70 to 80%. And then there's a discrepancy between the clinical appearance and X-ray. And this gives you a hint. This case most likely will be the altered passive eruption. But of course, even it might be an altered passive eruption, you still need to accurately diagnose it and verify it, which is the quantitative method. The most often used quantitative method is bone sounding. So as we all know, what is bone sounding? So basically, you have to give patient a local anesthesia, and the probe is all the way down to located where the crestal bone is. And then you pull the probe a little bit more coronally until you touch the CEJ. And this distance between the crestal bone and the CEJ is what you need to determine by your probe. But there are certain disadvantages for this bone sounding technique. The first is when the crown is very convex, it makes it very hard to detect the CEJ or the bone crest by the probe. And second is if the crown is very flat, it also makes it harder to detect the CEJ by the probe. Therefore, there's actually different instrument, a different probe facilitate for the bone sounding, such as the one here. There's a little bit round ball in the end of the tip. So in this way, you can easily tell where's the CEJ. And this is another instrument invented by Dr. Stephen Chu. It's a sort of curved probe. So in this way, we'll follow the root, the crown curvature better, and be able to easier to detect where's the CEJ. And the last disadvantage is, of course, you have to give local anesthesia to the patient. Therefore, personally, for me, if the patient come up with all 6 anteriors, or even including premolar, the full maxillary anterior, whole maxillary is affected or presented with this short clinical crown, I would actually prefer to send patient for a CBCT with a limited view. And actually, as we all know, with the limited view of a CBCT, the radiation is actually relatively small, very low. So as you can see here with the CBCT, everything is very obvious. You can tell how far is the CEJ to the crestal bone, and by the 3D rendering, you can even tell directly that the part of the clinical crown is definitely covered by the gingival. And here's a close view of the CBCT examination. As you can see, you can measure clinically how much is the crown, which is 7.5. And then you can measure on the CBCT, which the anatomical crown is 10 millimeter. And when you do the simple math, you automatically know there will be 2.5 millimeter anatomical crown was not exposed and covered by the gingival. And not alone about the crown, you can also easily tell how thick is the soft tissue and how thick is the buccal bone, which can furthermore guide you to choose the proper surgical technique for the crown lengthening procedure. So again, the reason I really want to emphasize the altered passive eruption is I think this phenomenon is not accurately diagnosed in the daily practice. As you can see, I encounter a lot of altered passive eruption. Is really if you really have a patient present to you with this square crown, thick biotype, and all the anterior teeth are involved, 90% of the time there will be the altered passive eruption. It might be 1A, 1B, 2B, but they're all altered passive eruption. And why is it important for me? So for example, these 2 patients, when they first present to me, they already have this provisional. They were referred by a restorative dentist. When a restorative dentist refer to me, they say, oh, I want you to do the crown lengthening on this tooth. So I asked the patient, why do you go to restorative dentist in the beginning? And the patient said, oh, because I don't like my crown shape. I want it to be longer. So I was like, this is how long that they can make it for you? And the patient said, yeah, and before it was shorter, but now it's a little bit longer, so I'm okay with it. And when I actually raise the flap and you see the prep is right, it's almost in half of the tooth. It's not even reached the CJ at all. And the same as this case shown here. So although both of this case are altered passive eruption, if this has been diagnosed properly by the primary doctor, and you can extremely lengthen the tooth in a much longer manner. So that's why I think altered passive eruption is a critical diagnosis that I hopefully you won't miss in the future. And as I mentioned, there's several differential diagnoses for the altered passive for the excessive gingival display. And actually, according to the 2007 World Workshop, the excessive gingival display is only a very small part of the periodontal diagnosis. As you can see, this is how complicated our perio diagnoses are right now. And you have so many diagnoses, and each square has almost 10 or 20 different diagnoses. So yes, it is a very complicated one. But here, other than this excessive gingival display, I really want to mention these two very important parameters, or let's say diagnosis, that I think you need to know how to diagnose this and don't miss it. So one is periodontitis, and another one is gingival phenotype. For the periodontitis, you need to check the pocket depth, the BOP, and radiographic bone loss, and basically it's the clinical attachment loss. And for the gingival phenotype, they actually include keratinized tissue width, gingival thickness, and a bone morphotype, which is basically the buccal bone thickness. And here I want to show you a case quickly to illustrate why I think these two parts are very important. So here comes a patient who is very young, 25 years old, male. And I don't know if you can give a guess why this patient present in the perio clinic. I mean, I'm not going to really ask you this question, but I just give a guess why this patient come to see a periodontist. You probably will never imagine until I show you the x-ray. So if you look at the x-ray, you will never, if you don't take an x-ray, you probably will never imagine this patient will have a bone loss like this, right? So let's take a close view of the posterior. So this is the initial. As you can see, apparently the patient was diagnosed as periodontitis, aggressive periodontitis. And compare the initial and after SRP, the most obvious change is you have black triangle. There's a loss of papilla and very big black triangle. And of course, patients start to complain, I have food trapped, and every time I talk, I feel my saliva go through my teeth. And I told him, yes, these are all normal. And if later on you do the same thing for the anterior, this will happen to the anterior too. So this doesn't only happen in the posterior, it definitely absolutely will also happen in the anterior. And thanks Dr. Bro for all those pictures showing that just by doing SRP, you're going to have a loss of papilla, increase of the interproximal embrasure, and the recession. And imagine if you didn't diagnose the periodontist and you went ahead to raise the flap, do the surgery, and same thing will happen to the patient. So back to this case, unfortunately, this patient is not a crown lengthening patient. But imagine if the patient's chief complaint is, doctor, I have a gummy smile and I have a shorter crown. I want to do crown lengthening. And you didn't check the pocket depths. You didn't diagnose periodontitis. And you go ahead and do a surgery with open flap. What's going to happen is patient will end up with all this black triangle and a lot of complaint. So the periodontitis, which in my opinion really needs to be addressed and to be diagnosed before you decide to do any surgical procedure for the patient. And for the case like this, let's say if the patient has did have a periodontitis and still want to do the crown lengthening, and you need to discuss with the patient the possibility of the black triangle, and also discuss with the lab technician and the restorative dentist that possibly you need to cover or camouflage this black triangle with square shape of a crown. Another case here, and I want to show you, is to talk about why the gingival phenotype is important. So this case, based on the New World Workshop classification, is diagnosed as gingival recession, RT3, and there's some lack of keratinized tissue, and also it is a thin biotype, thin phenotype. So here, as you can see here, is the recession of the tooth central, and based on the knowledge we have of biologic width, you can probably give a guess. This probably will be the line of our osseous crest, right? So here's a picture of I raised a flap, and yes, you're absolutely right. You can see here this two teeth with the recession, the bone crest is much lower than the contralateral. However, what I want to point out is here for this tooth. If you remember before I raised a flap, there's no recession for this tooth at all. There's no deep probing of this tooth. Everything looks very normal. However, when you raise a flap, you see a completely different story. So here the message I want to deliver is the absence of buccal bone doesn't mean recession. And if there's no recession, it doesn't necessarily mean there must be a buccal bone present. So what will happen after the flap is adapted? Let's say if I put the flap back, close it, send patient away. So what happened? What's the healing outcome of this tooth? So according to our study and knowledge, right now we know if there's a thick phenotype, and most likely there will be no change. You will have no recession, and the margin will be maintained. But if it is a thin phenotype and there's possibly high chance of recession will occur. And here's a courtesy of a Dr. Wogmas, who's an excellent endodontist, and he shared several cases with me. So he actually basically just did the endosurgery for these two cases. And as you can see, this is a tooth with a sinus tract, and he went ahead to do the apical surgery. And both cases are thin biotype. And look at what happened in the post-op. The recession occurred. So imagine for these two cases, and the patient come to you for aesthetic crown lengthening for the central and lateral, and after surgery you start to have the recession, huge recession of this canine. Do you think you have a happy patient? I'm not really sure. So therefore, if the patient of you has a very thin phenotype, you really have to think about flap management. How can I change the thin phenotype to the thick phenotype? So for this case, what I did is, actually this is not a crown lengthening case. The patient was referred for the purpose of corticotomy, to accelerate the ortho treatment, because it's going to have a ortho treatment. So what I did is, after the decortication and corticotomy, I did a bone graft and soft tissue graft, both, to change the thin phenotype to the thick phenotype. And here's the initial and surgery and 2 years follow-up, post-op. So as you can see, even with the buccal dehiscence, the 2-year post-op showing that the soft tissue margin is still maintained very stable. And actually, if you look at it here, and the soft tissue biotype is completely changing from thin to a thick one. So the take-home message too here is that the aesthetic evaluation of incisor edge and tooth proportion is very important. And for the periodontal evaluation is as well as important to diagnose altered passive eruption. And you need to confirm the periodontal condition of the patient. And the last but not least is the phenotype of the patient, which means the soft tissue and the bone. So, and the oftentimes I was asked, the question I was asked is, what do you think is the best surgical guide for the crown lengthening procedure? And I'm pretty sure this is probably some of you want to know the answer. Here I want to make two examples of different scenario. For the case on the left if after aesthetic evaluation, you decided you determine that restoration is needed, and then the surgical guide will be fabricated. However, if you diagnose the case of altered passive eruption and there's no restoration needed, and therefore there's no surgical guide needed, the natural CEJ of the tooth will be your surgical guide. So here's the thing that I really want to make it clear, because a lot of people think that every aesthetic crown lengthening case will need a surgical guide, which is not. If there's an altered passive eruption case, you don't need a surgical guide. So here's a case presentation showing about the case of altered passive eruption. So again, emphasize it again, as you can see here, for the clinical appearance, there are short and square clinical crown. The all anterior 6 are affected. Actually, for this patient, it's all the way down to the premolar. Gingival display is more than 2 millimeter, and it is a thick phenotype. And if we take close view for the X-ray, you can see the discrepancy between the clinical appearance and the X-ray examination. So basically, this is the altered passive eruption type 1B case. And for this case, I already verified it with the bone sounding. I'm just going to skip this part. So the treatment plan for this case is gingivectomy plus the osseous resection. However, for this patient, she's a young patient, 25 years old, African-American female, and she doesn't want to touch the bone because she's very scared. So she said, I want to try the gingivectomy first. I don't want to touch the bone. So I said, okay, fine. I will just do a gingivectomy and show you. But I guarantee you the gum will grow back. She said, okay, fine, I will see. So what I did is I went ahead and did a gingivectomy only by just a blade and a little bit of plastic with a high-speed burr. And this is the initial and 3 months post-op. As you can see, you barely see a lot of changes. So as I told patient, I told you the gum will grow back. But at the time, patient said mentally, I'm not really ready to do a big procedure to remove all the bones. So she didn't agree with the osseous reduction surgery. And 1 year later, the patient actually came back and she said, I got a little bit extra money and time and I want to do the ortho. And now I think I'm ready for the bone surgery. So, okay, fine, and let's do it. So here's the 1 year later after I did a gingivectomy. So now this time we're going to do a real aesthetic crown lengthening, including gingivectomy and osseous resection. And again, here we don't need any surgical guide. So the first thing is you mark the CJ with the probe, and then you use the 15C blade to kind of highlight roughly where the CJ is, and just go with a scallop shaping. And here you don't necessarily need to be very accurate. Even the CJ is a little bit like wrong, like a little bit shorter, more apical, you always can trim the excess gingiva later, because as you can see here, this patient has a massive amount of keratinocyte tissue, so you can feel free just to cut if your first line is too apical compared to the real CEJ. And this is after the gingivectomy. So the incision I'm doing here is a papilla sparing incision and with a full thickness flap. And this is what it looks like after I raise the flap. And let's take a close view. As you can see here, especially for the lateral here, and if you move to the back, the canine and the premolar, the CEJ is even covered by the bone. You couldn't even identify and locate where the CEJ is, let alone you don't have sufficient room for the biological width. So I started the osseous resection part, and these are usually the burrs that I use for the osseous resection. And the first one is called an end cutting burr. As you can see, this burr only cut in the end, and the side is very smooth and doesn't damage any root surface. So when you use this burr, you can freely just place this burr leaning it on the tooth surface and not worrying about it's going to damage the tooth structure. And then after using the end cutting burr, you're going to have this ledge at the bone, as you can see here, because it's a very thick buccal bone. After removing this, after using the end cutting burr and showing this ledge, you have to change to a diamond round burr. It can be big, it can be small, but the point is you have to all smooth this ledge out and thinner this all buttressing bone. And here's a view showing the post-op. After smoothing everything, you see everything is smooth, clean. There's no ledge anywhere, and you even need to do some grooving between the tooths. And here's a pre-op and post-op. As you can see here, I did at least a 3 millimeter osseous reduction. And here's the point that I also want to mention is about interproximal. A lot of people doesn't want to touch the interproximal because they are afraid of any papilla, loss of papilla, black triangle, because that is the worst thing that could happen after surgery. And that's a very bad aesthetic complication, very hard to resolve. So some people, they don't want to touch it. But for my opinion is like you still need to establish a healthy biological width at the proximal side. As here you can see, I didn't go crazy at the proximal side, but I still went ahead to trim and make sure there's sufficient biological width there. If you don't do that, what you're going to end up with is this always inflamed papilla between the two restoration, as you can see here in another case. So basically, this is the immediate post-op, and the suture here I'm using is polypropylene, is a non-resorbable suture, which is 6O. And the suture technique that I often use for aesthetic crown lengthening is either interrupted or vertical mattress. You can go either way, whichever you feel comfortable with, it will work. And regarding for the suture material chosen, I personally prefer the monofilament suture because it has less plaque accumulation, and I don't need to worry about the hygiene of the patient. And this is a pre-op and compared to the post-op, immediate post-op, and pre-op and immediate post-op. And this is a 3 months post-op. So at 3 months post-op, then patients say, right now I'm happy with the crown lens, but I'm not really happy with my pigmentation. So I went ahead and used a high-speed burr, just did and the round burr did the pigmentation removal. So this is a 3 months after pigmentation removal, which is 6 months after crown lengthening. So if you look at initial and post-op, and now we're really talking about aesthetic crown lengthening, not just gingivectomy for a short-term outcome. And if we compare to the anatomic CEJ and to what we have right now, if I draw a line for the anatomic CEJ and up to here, you can see we have a little bit of soft tissue rebound, but it's a healthy sulcus, like roughly 0.5 millimeter to less than 1 millimeter, which is considered pretty healthy. And there's another case of altered passive eruption type 1B. And again, it's a similar situation. I did a gingivectomy and the osseous resection. What I want to mention here is if you compare both cases, first this is initial and this is a post-op. As you can see, the crown lens is extremely lengthened compared to the initial. The reason I mentioned this case here is if you compare the one I showed before, and actually you can appreciate that I did much more osseous reduction in this case compared to the one to the left. So basically I did more than 3 millimeter osseous resection in this case. The reason is in the left case, it is a thick biotype, but it's a thick scallop. And the right case is a thick biotype and a thick flap. So basically, the right cases have an even thicker biotype. So to prevent certain or more soft tissue rebound, I decided to went ahead to do more osseous resection. So for this case, I actually did a 4 millimeter osseous resection. So Again, I want to emphasize the importance of osseous resection in by this case. If you remember that the patient came, had a surgery done, and was very happy, but then came back with complaints saying, I feel like my surgery didn't work. So if you have an altered passive eruption case, the sufficient osseous reduction is even more critical, because you don't really have a second resolution of restoration. You cannot counting on restoration because it's all purely patient's own teeth. So if you don't do a sufficient osseous reduction, you're going to end up with quite a big amount of soft tissue rebound. So the take-home message 3 here is, for the excessive gingival display, if you diagnose it as an altered passive eruption, there's no restoration needed. And the surgery without guide, you don't need any surgical guide, you just need to follow the CJ. If the thin biotype, you remove 3 millimeter. If it's a thick biotype, you remove more than 3 millimeter. And then case is complete. No specific, no need for veneer, no need for extra crown, and just counting on patient's natural tooth. So I actually lost my time track because I quit it in the middle, but I think it's around the 45 minutes, right? So the oval. I actually have another probably like 15 minutes more, but I don't know if you want to continue or you want to leave it for in the future together with the crown lengthening, the functional crown lengthening part. So basically so far it's the aesthetic crown lengthening part, specifically in the altered passive eruption.
Okay. I think you could go ahead and finish up the 15 minutes. That's fine. We'll have some questions for you.
Okay.
Panel Kamis, are you there? Just hold on for a little bit. Let me see if I can get Panel. Panel asks a question that if after crown lengthening there's been rebound. I want him to ask the question himself. Panel, are you there?
Hi,
Yeah,
yes,
go
I'm
ahead.
here. I'm here. Hi, I had a case in practice that I did some crown lengthening on, and then the veneers were put on a bit too early, sort of 3 months before the 6-month healing. And she developed this invasion of biologic width afterwards. And now my question is, how do we rectify this situation? Do we take the veneers off, let the tissues settle and rebound, and then repeat the crown lengthening? Or do we redo the crown lengthening using the veneers as the new restorative margin?
Oh, I got it. So I think you mean the veneer was delivered, cemented.
Yes,
and then
it was.
a couple of months later, the tissue rebound more, and the patient start to have some gingival inflammation, or the crown becomes shorter again, right?
Exactly,
That's what I mean.
exactly.
Okay,
Yeah.
so at this point, I think if you like the veneer, like the moment that you cement it, if you like the lens and the patient like the lens, you can go ahead, do a second surgery, just modify the previous crown lengthening, because apparently there was insufficient osseous reduction at the time. That's what I think, But using the veneer as your surgical guide, and went ahead to do a crown lengthening and modify it. Yeah.
My only question about that, sorry, last question I'm going to ask is, if the tissues are inflamed because of the biologic width violation, and you are raising a flap, with regards to sort of post-op healing, how predictable can it be with regards to sort of recessions or getting predictable healing in raising a flap in inflamed tissues?
That's actually a very good question, because for my philosophy is I don't do surgery on the inflamed tissue. There are two types of inflammation. If the inflammation is, let's say, for example, caused by the plaque or like those type of inflammation, but it didn't get hyperplasia, it's just redness. Okay, so for this type of inflammation, if you go ahead and do a Cavitron and localize SRP, it will temporarily resolve the inflammation. For example, you probably need to numb the patient a little bit, because it's not just a superficial cleaning. You need to go a little bit to rupture the epithelium a little bit and let the tissue heal. So in this way, the inflammation will temporarily go away, and you need to do the surgery almost like 1 or 2 weeks after you did this superficial or shallow SRP, because at the time the tissue is still not inflamed. But if you wait longer, and the inflammation will come back. So that is the tricky part. But if the tissue become like granulated, granulomatized and hyperplasia, and then you actually need to end up cut off those inflamed tissue, because even you do SRP, it's not going to go away.
Great, thank you very much.
No problem. So should I answer the question so far, finish the question so far, or should I finish the presentation first?
I think you can finish your presentation. I just wanted to get panel off. Panel, where you calling from?
I'm calling from London.
Okay. Well, nice to have you here.
Thank you very much. It's been very good.
All right. Oh, go ahead, Doctor.
Nice to have you from London. Okay, sure. I'm going to continue. Mm-hmm. Okay, I really appreciate, because, I'm trying to cut off so many slides, but also I wanted to, give proper information to the audience. So it's like, I don't know how to cut off everything within 45 minutes. I'm really sorry about it.
No problem.
Okay. So far we talked about the autopath eruption situation, which requires no surgical guide. And then the other case will be the opposite, is the restoration needed, and of course the surgical guide is needed. So for the case of restoration needed, the first thing you need to do is aesthetic evaluation. As I mentioned it before, the incisal edge, tooth proportion, gingival margin, etc. After the aesthetic evaluation, you need to do a wax up. Either you can do in the traditional way with wax, or right now you can do a digital way in the DSD design or any other digital technique. And then you need to transfer this wax up or digital wax up into a mock-up in the patient, and make sure the patient is happy with what you presented and what you proposed of the new tooth proportion. Because at this moment, for this case, the patient doesn't have their own natural CEJ, so there's no reference. Whatever patient will have is your opinion, okay? And then eventually this mock-up will become your surgical guide. Now we're talking about what are the best surgical guide for aesthetic crown lengthening. So basically, there are two types of surgical guide. One is a removable, and another type is a fixed guide. The removable guide are most commonly used one. They can be this type of gauge. It's invented by Dr. Chu and Dr. Fleischer. And you can have this Essex fabricated. You can use the mock-up. And also right now, because the involvement of digital technique, you can have this Dura guide and 3D printed, and to guide you both for soft tissue cutting and the bone cutting. For the fixed guide, basically is talking about the prosthesis, such as veneer, provisional, all those are your fixed guide, because you deliver it and you don't remove. And you are using those restorative margin as your final margin and guide you to do the bone reduction. So this is the one of the surgical guide I mentioned. It's called a T-bar, and the I-bar is invented by Dr. Stephen Chu and Fleischer. And as T-bar, I mentioned before, it's to determine how much crown width length ratio that you wanted to give to the patient. And this actually is to guide you how much bone reduction you need to do. So for this tool, the ratio here is 78%, and the osseous reduction here is 3 millimeter. And the way how you use it is illustrated in this article by Dr. Fleischer. As you can see, the patient present with the chief complaint of a gummy smile. So you can just use this bar and put the incisal edge on this little platform. So you can tell if the width is roughly at the outside border of the red, and which means the highest margin should be at the top of this red mark. So this is how they went ahead and opened the flap, and they changed to this I-bar, and this is guiding them how much bone reduction they need to do. So here's the illustration of how to use this one. And this is after the I-bar, and they know this is after their osseous reduction using the I-bar, and then they put the flap back, and this is what it looks like immediate post-op, and eventually they change to the longer crown. And this is the how to use with the Dura guide. Personally, I don't have experience for it, and I haven't encountered the cases using this digital technique. But it is relatively very simple to understand it. You basically just need to locate it where's the ideal margin, and you have this 3 millimeter in between. It depends. This guide, it looks like only 1 or 2 millimeter, but it's up to you. So how much bone reduction that you wanted to do. So here, the lower margin is to indicate where you should cut the soft tissue, and the higher margin is where you indicated you should cut the bone. And also, you can use a mock-up as your surgical guide, and you do Lexington suction and do a mock-up for the patient, and you don't remove the mock-up. You just use the blade and follow the mock-up and to do a gingivectomy. So the good thing for using mock-up as a surgical guide is it is smoother margin, as long as your material is smoother, and you follow the tooth shape very well. Because it's a mock-up, you know, the mock-up should be ideal, aesthetic, and the patient should be very happy about the result. But the downside for the mock-up is because it is very easy to break, and once it breaks, you cannot really put it back. So if you use it for gingivectomy and then breaks, you cannot really use it for bone reduction anymore. And Esthetic guide is actually most commonly used for the aesthetic crown lengthening because it's easy fabricated and it's seated well and it's clear. You can see very well. But there are several points that you need to keep in mind to make sure this guide is really working. The first thing is you have to use a certain rigid material. You cannot use those material that are really flexible. In this way, it will rock. It will not give you a very proper position of the margin. And second, it has to be well seated and needs to be clear and ideal margin. And most important is you need to have an interproximal contact. As I mentioned before, if you don't do the certain reduction for the interproximal bone, you will end up with a inflamed papilla all the time. So these are some Google photos illustrated the not ideal surgical guide by SS retainer. So here, as you can see, the one is not seated. You see, the guide has a lot of space between the tooth, and the margin here you can see the material is very rough compared to the mock-up. It's not smooth at all. And even for this one, they basically just make a hole to locate it where the highest point of the margin, but there's no indication of or no shape of interproximal contact at all. So these two are not what we are looking for. So some quick tips especially for some student or some like young clinician, if you decide to do the surgical guide yourself. So here's some tips. First, you have an original cast, and then normally you would do a wax up on the original cast, with this blue indicated. And then majority of people will do an Esthetic guide above the wax up. This is not right, because if you do a surgical guide based on a wax up and then you put this guide back to the patient and patient's mouth, it will not fit. It will have a space, right? So this is not the right way to do it, as you can see here in the Google photo. So this is a guide fabricated on top of a wax up. Of course, it wouldn't seat it well in the patient's mouth. So the proper way is to do it is do the Esthetic guide on the original cast without the wax up. So you will have to have two sets of casts. One cast you give it to the lab or you do yourself for the wax up and may fabricate a mock up. Another set is you have to do the Esthetic suck down on it. And then a little bit downside for this technique is once you raise a flap, you will have this Esthetic flange, like a non-support, and it's really like flexible there, especially if your material is not very rigid and it has a discrepancy distance from the guide to the bone. So what I personally usually do is that I just mark where my margin is on the cast and trim the stone away by a high speed. And then just do a suction on this one. So in this way, it will be much closer to the bone and you don't have the issue with non-fitting. So here's the illustration showing what is a proper Esthetic guide and what is a non-proper Esthetic guide. And so for the advantage of a removable guide is that it's clear visuality and it's easy sitting, and there's no interference to soft tissue healing because you remove it after surgery. And there's a less visit. Basically, all the work you need to do is when the patient is not here. It's the lab work. But once the patient's here, you just need to put the guide on. And of course, there's no need for gingivectomy or provisional preparation or repair. And of course, there's a disadvantage. And otherwise, I wouldn't talk about what's the advantage of the fixed guide, right? So the disadvantage for the removable guide is the risk of hypersensitivity and the less aesthetic satisfaction. For example, for the top case, and as you can imagine, I kind of expose certain of the root surface because I need to bring the margin more apically. So the patient will have certain hypersensitivity during the healing. And a second case showing there's some patient, they have this very black root surface. So after you do this aesthetic crown lengthening, all this will be showing during the healing phases, which is very non-aesthetic. So this two disadvantage leads to the fixed guide, which is the provisional. So here's a quick illustration to showing how to use the provisional as a fixed guide. So basically, if there's a patient first come with a chief complaint saying, I don't like my crown, it's too short and have a gummy smile. So as a restorative dentist, you have to go through all the aesthetic evaluations, such as incisal edge, tooth proportion, as I mentioned, and then you're gonna go ahead and do a mock-up. After mock-up, you will need to use a 15-3 blade to do a gingivectomy. And after gingivectomy, you will do your crown or veneer preparation right after gingivectomy. And then deliver the provisionalization at the same day. In this way, you are temporarily violating a biologic width. Actually, exactly just as the previous doctor mentioned. So you're temporarily violating a biologic width, but you cannot wait for too long. You have to wait for once the soft tissues heal, which is 1 or 2 weeks, you have to go ahead and refer this patient to a surgical dentist or you yourself and go ahead to do the surgery. So then once the provisional is in sight and you will go ahead and do the crown lengthening surgery with a full thickness flap and do the osseous resection. Once the osseous resection done, you place the flap back exactly where the provisional was, like right at the provisional margin. This is an immediate post-op, and this is 2 months post-op. And then after 2 months post-op, there's no any delayed healing. Everything looks fine. You refer this patient back to the restorative dentist if these are two different dentists, or you can start to thinking about final restoration. So as you can see here, the pre-op, surgery, and post-op, the patient didn't have to go through any hypersensitivity or non-aesthetic phase. So basically the advantage for it is the fixed guide, you can use it easily for bone reduction, and it has aesthetic satisfaction. There's no risk of hypersensitivity, and there's no prep during the healing period. Basically, the patient wearing this provisional all through the healing period. As long as the provisional is not broken, you don't necessarily need to see patient and readjust a lot of things. So there's no additional visit for new provisional. Once the tissue is all healed after 3 months, it's directly remove the provisional, take a final impression, and then send to the lab. Of course, there's also disadvantage for it. So let's take a look at this case. So if you have a patient who, like you got a patient referred with this such type of provisional in the mouth, it will not be an easy surgery for you. First, as you can see, the margins are all over the place and none of them are really matching each other. And the contact point is really high and make it a very square-shaped tooth. So it is not an ideal provisional. Once I raise the flap, it's actually even worse. So as you can see, the two centrals are not at the same level, and the prep on the lateral are basic on the enamel. It's not even deep enough, so it's insufficient prep. And during the procedure, one provisional broke, and there's another one has such overhang that I cannot even place my burr in a proper angulation. And if I take a close view of this tooth, the lateral incisor, and if you remember what I talked before, this is 3 millimeter biologic width from the CJ to the crestal bone. So for this tooth side, I don't need to do any osseous reduction. It has sufficient room and the distance for biologic width from the CJ to the crestal bone. And if you compare it to the pre-op, like without the flap was opened, and you see the patient actually have an excessive gingival display on this tooth, after even so yes, here, so as you can see, the CJ is 3 millimeter away from crestal bone, which is very sufficient for biologic width. So this tooth doesn't need any osseous reduction. And if you compare it to the pre-op, then actually this tooth has quite a lot amount of excessive gingival display. So this case is actually autopassive eruption type 1A, which has excessive gingival display and enough keratinized tissue, but the bone crest is at the ideal position away from the CEJ. So for this case, I don't need to do any osseous resection. Technically, I just need to do a gingivectomy. So because of this non-ideal contour of provisional or veneer or crown, it resulted in the inaccurate diagnosis. It prevented me to do the proper bone sounding. My probe cannot really angulate it well. So again, the disadvantage for using provisional as a surgical guide include the additional surgical procedure, because you have to do the gingivectomy first. So you need to numb patient first. And then you actually loss of keratinized tissue because you do the gingivectomy. And then there's a subgingival crown margin. It makes it difficult to probe, and it may lead to the misdiagnosis. There's overhang. And besides, if the provisional broke during the healing time, you have to see the patient again, and multiple visits just to repair the provisional until the healing time is complete. So here we see that there's actually advantage and disadvantage for both type of guide. For the removable, you have the disadvantage of risk of hypersensitivity and less aesthetic satisfaction. For the fixed guide, you actually have the disadvantage of overhang, multiple visit, and additional surgery. So is there any other options? The other option is doing a new provisional, of course. And the question here is, when can we do it? Because we know for the final restoration, we better wait for 3 to 6 months. So when can we make provisionals? This is an article that I've been using, and also as my clinical reference, and I've been following this surgical technique. So in this article, it mentioned the 3 interval that you can do the provisional preparation. The first is intraoperative preparation. Basically, you just do the preparation and do the provisional at the same time of surgery. And there's an early preparation, which is prep the provisional at 3 weeks post-op. And then there's daily preparation, which is after complete healing, which is 6 months later, and you do the provisional. For the first one, of course, you can imagine the downside is that you have to deal with all this blood, water, and high speed. So it might be a little bit messy. So that's why for me, and I always use this 3 weeks post-op. So here's a case. I will show you a case quickly, illustrate how does this work. And the key point for this early preparation at 3 weeks is you cannot do a subgingival preparation. You have to do a supragingival feather edge preparation. So in this way, you don't interfere with the healing. So for example, this is a case of showing illustrating what is the early prep. So the patient was referred to me from the restorative dentist for aesthetic crown lengthening. So here you see is the provisional, but when the patient first presents to you, it could be a cracked PFM or old PFM. So as a restorative dentist, the first thing you always do is remove the old PFM and change to provisional, but exactly same shape and contour as the old PFM. And then the restorative dentist will refer this patient to me as a surgical dentist, and then will also provide me a removable surgical guide. So I will use the removable guide and then go ahead and do the surgery. And here, as you can see, this is healing. So patient will experience certain hypersensitivity and the non-satisfaction aesthetic outcome. But we don't need to wait for 3 months. So at 3 weeks, once I remove all suture and everything healing was nicely, no inflammation, I will refer back the patient to the restorative dentist. And at this point, the restorative dentists are able to do a new set of provisional, as long as you do it as the supragingival feather edge manner. And then patient will wear this new provisional and all through this healing process. And during this healing process, you don't touch the margin too much. The only thing you can change and you can reshape is the contact point. You can bring the contact point a little bit lower or a little bit higher, just reshape the interproximal a little bit more. So this is the 3-week early prep procedure, which means you prep the new provisional at 3 weeks with a feather edge, supragingival, and only modify the contact point during the healing process. Because once you do a subgingival margin, you will interrupt the healing. So the take-home message for here is that if you have a case and after the aesthetic evaluation, you determine that the restoration is needed, and you're going to go through WAXA, mock-up, surgery, waste the guide, and the restoration, eventually case complete. So I think I finally finished it, and just a very quick review. So the take-home message 3 is, if the case is autopath eruption, you don't need this restoration and you don't need surgical guide. And if the thin biotype is 3 millimeter, if the thick biotype is more than 3 millimeter, and then case complete. And of course, you need to do aesthetic evaluation, including sizo age, tooth proportion, and some other parameters. And the most important is the periodontal evaluation. Don't forget the autopassive eruption, diagnose properly of the periodontal condition and the phenotype, including soft tissue and bone. And that's the first one that I mentioned, is the healing time is for the aesthetic is 3 to 6 months. Non-aesthetic, which is functional crown lengthening, is 2 to 3 months. And there are several factors will affect the outcome, but the most important will be the sufficient osseous reduction. And then the thin biotype is 3 millimeter, and the thick biotype is more than 3 millimeter. So that finished.
Dr. Shi, I can't hear you. Are you mute?
Account or
Okay.
something like that.
All right.
Okay,
Right.
sure.
Thank you.
Okay.
Thank you for that. Very, very detailed.
Thank you very much. I really appreciate it.
You have a lot of questions here. I'm going to start off with Miriam. Miriam, are you there?
Yes, doctor.
Yes, go ahead. I know you have a couple questions. Go ahead and ask the questions.
Okay. First of all, thank you, doctor, for this informative lecture. And I have a couple of questions for you.
Mm-hmm. Sure, go ahead.
Okay, doctor, in the cases of crown lengthening that need bone contouring, why the repositioned flap should be tension-free?
You mean whether the flap should be tension-free or not? That's
Why?
your question?
Mm-hmm.
Why?
Yes, in cases of osseous yes.
Oh, okay. So first, I don't think you need to achieve tension-free closure for the crown lengthening. I didn't mention that in my lecture neither. Second, you will not have a tension for your flap, because imagine you are removing bone. So let's say your flap was attached, and you remove a bone, so the flap will be loosened. So you will never have a tension in your flap.
I read it in an article in Research 8.
Okay. If the article mentioned about tension-free closure, it's just the way they're saying it. But there's literally no tension of the flap. If you really think about it, that's my opinion. Yeah. So imagine you open it, you remove more structure, you put it back. There's no way as a tension. The only tension that you create is when you're doing guided bone regeneration, because you are building up more things. When you have a more bone and you have to cover it, and of course your flap will have tension. But usually when you remove all the bone, you adapt the flap back, it's passive. The only concern here about flap adaptation is, should it be coronal or should it be apical? But the tension or not tension, I don't think there will be really tension in the flap for the crown lengthening procedure. Yeah.
Okay, doctor, my second question, how to reestablish the supracrystal tissue attachment after crown lengthening?
How to establish? That's your question?
Yes.
Okay, so basically, as long as you maintain the room, the numbers, let's say 3 millimeters, the supracrustal attachment, which is a biological width, will form by itself. You don't need to establish anything. The only thing you need to do is give it time. The moment you put the flap back to the tooth or to the root, the first 1 to 2 weeks, the epithelium will start to attach on the root. So at first it will seal on the coronal portion. So the epithelium will attach on the root, so it seals. And then you remember the first line is junctional epithelium, and then it's a connective tissue, and it's bone, right?
Yeah.
So the moment you put back the flap, the first in the 2 weeks, it will seal the coronal portion by the junctional epithelium. And then the connective tissue part will gonna start to work on itself. In the beginning, it will be not organized, and by the time it is time to maturation, and then will become organized, and the sharpest fiber, everything will go to the cementum. So you don't need to do anything, just need the body to heal.
Thank you very much, doctor. Thank you very much.
No problem.
All right. Azi Malik, are you there?
Hi.
All right. So can you ask a question?
Yes. So my question is, there is another surgical modality, which is where you do osseous resection first and do not do a gingivectomy. And then a few months later, you go back and then just do a gingivectomy. Do you think that's predictable? It's often the case, particularly around implants, where you want to avoid multiple surgeries, and you've got a tooth that you want to crown lengthening around an implant that you're placing, for instance, and you can just remove the bone at the time of when you're placing the implant, and then do a soft tissue resection at the second stage. Do you think that's predictable?
Well, first I have to say the outcome of osseous resection, the tissue rebound, which is really, you cannot really come with one number and use this number for every cases. Every patient is different. And so far, we don't have a really article talking, oh, if your flap is 0.7, you need to remove 3.5. There's no such article about that. So there's always a chance you need to do a second gingivectomy after you do the osseous resection. So the additional gingivectomy is always, you need to be prepared. But if you're talking about don't do gingivectomy at all, just do osseous resection. If you remember the autopath eruption case that I showed, like with a very thick flat case, remember? For that case, if you remove so much bone, 4 millimeter bone, but you don't remove any soft tissue, you end up with such a deep pocket there during the healing. Am I right? So yes. That's why you're always going to do the gingivectomy, but it doesn't necessarily need to be the perfect one. It can be a little bit shorter. It can be a little bit too much, because if you cut it shorter, you can, after the healing is done, and you know there's a sufficient distance between the crestal bone to the CEJ, so you can just numb the patient, do a localized gingivectomy. That's fine. If you move it too much, don't worry, because the body is gonna re-establish soft tissue, and they will have tissue rebound. So literally, as long as you have a proper soft tissue, the bone distance away from CEJ, the body will do the job.
Great, thank you.
Yeah.
Azi, where you calling from?
London.
Okay. Are you in a program? Are you in a residency program, or you're practicing?
No, I'm now practicing. We finished it, so but we're almost nearly qualified. So.
All right. Congratulations. Thank you so much for joining us, and hopefully we can have. This is going to be a dental learning community. We are hoping to build, bringing everybody from around the world to learn, from those who have spent time practicing and learning as well. Thank you so much.
Great. It'd be great to get involved. Thanks.
Okay.
I see there are several questions also in the QA. Should I go ahead and answer it?
Please go ahead.
Okay. So I'm just gonna start from the first one. And there's no sound. Okay. For Dr. Williams, can orthodontics alone correct the problems of incomplete eruption for the active phase? If there's an altered active eruption, the ortho can do it, because it basically means the tooth is not erupted from the bone. But for the altered passive eruption, the ortho cannot do anything, because it's talking about the soft tissue going apical. So imagine if you put the braces on the teeth, you only control the tooth, apical coronal. It doesn't control soft tissue. So it ortho extrusion can bring the soft tissue down, but cannot bring the soft tissue up. So orthodontics alone cannot correct the altered passive eruption. And is bone removal both buccal and palatal buccal alone? Okay, that's actually a good question, because for aesthetic crown lengthening, it's only in the buccal and the proximal possible, but not the palatal. That's actually called aesthetic crown lengthening. So aesthetic crown lengthening doesn't necessarily mean it's because it happened in the aesthetic area. For example, if a patient fractured the tooth, the central incisor, and the fracture line is very deep, and the patient wants to keep the tooth and restore it, it doesn't want to extract it, you have to do a circumferential crown lengthening, both buccal and the palatal. And then this is called functional crown lengthening, because your purpose is to make more tooth structure and make this tooth restorable. And this is what we call functional crown lengthening. And if you only do the buccal, that's purely for aesthetic reason, then it's aesthetic crown lengthening. So for aesthetic crown lengthening, the bone reduction is only on the buccal and the proximal, but not including the palate. In the case where there's a sensory incantation, you need to due to the flat design suturing technique. Oh, okay. Yeah, I didn't really include any cases for that because it's, to be honest with you, I rarely seen
here.
Go ahead.
Okay. I rarely encounter for the alter-passive eruption 1B case in the thin biotype. So far, the case I encounter are all thick biotype. But I definitely encountered the thin biotype in another case, for example, gingival hyperplasia. So the way I do it is still full thickness flap. And the only key point here is the suture. So you need to do something called periosteum anchor suture, which is a kind of a suture right in the apical of the vestibule. So in this way, the flap will be secured at an apical manner. So you don't need to worry about it. It goes more apically. So after you do the periosteum anchor suture in the vestibule, and then you could go ahead and do the either interrupt or vertical mattress as I showed in the lecture. Yeah. It's a second stage crown lengthening predictable, where initially only osseous reduction is done, followed by a soft tissue. Second stage crown lengthening, where initially osseous reduction, I didn't quite understand this second stage crown lengthening procedure, where initially only osseous reduction is done, followed by a soft tissue. Is this doctor here, Dr. Malik? Do you want to elaborate your question a little bit more? Okay, I'm going to continue for next one. Can we use air eroder with end cutting burr for osseous?
That's Banning,
right? Eroder? Huh?
Okay, is that from Banning? This one you're reading now?
No, it's anonymous attendee.
Okay.
Yeah. What is an eroder?
Eroder.
Sorry, doctor. Yes. Sorry, I think this question is from Iraqi participant. He's speaking about air motor.
Air motor. Air monitor? Air motor.
No.
Is it a...
It's like, how can we explain? It is like the regular handpiece that you use. Yes. So I think he's speaking.
I guess yes.
Can we use?
I use regular handpiece, regular high-speed handpiece. It's just a burr.
Yes,
it doesn't matter with the handpiece. Yeah. Usually it's high speed.
Okay.
I don't think you can use low speed on this thing. It will take you the whole day to remove the bone.
Okay.
Place was the guy.
أعتقد جابوا سؤالك زميلنا.
Sure. And then what's the guide to the amount of bone to be removed? I think I answered this several times, and actually a good question. I'm going to emphasize again. So 3 millimeter for thin biotype and more than 3 millimeter for thick biotype. For this part, actually, it is easy for me to say 3 millimeter, 4 millimeter, 5 millimeter, but it is very hard to do. So in my early residency, even I know it is 3 millimeter, but I'm so scared to remove so much bone because, we've been talking about how to preserve the buccal bone, do immediate implant. You cannot remove the bone. So imagine we are talking so much about maintaining buccal bone, then now I'm removing 5 or 4 millimeter of buccal bone. It is scary. So my recommendation here is especially for the autopassive eruption case. If the patient came with autopassive eruption and seeking for the treatment, you need to remind the patient there's a chance he or he might need a second surgery, just to compensate that the first surgery you didn't do enough osseous and then the severe tissue rebound happened. And then you always can go ahead to do a second surgery. Of course, it's a second surgery for patient, additional cost, additional trauma. But if you want to be preservative, you don't want to cause any future problem, then just remind patient there's a possibility